Okay. All right. Okay. So, good evening, everyone. So, Dr. Ayodeji is going to be taking us on acyanotic heart disease, the obstructive type. So, Dr. Ayodeji, you have the floor. You can please present. Thank you.
Okay, good evening, Prof. Good evening, everyone. Presenting the obstructive congenital disease, and that comprises of the pulmonic stenosis, aortic stenosis, and coarctation of the aorta. That's my outline. So I'll be taking the pulmonary state, which is there's a malformation leading to the obstruction at the level of the pulmonary valve, and it forms about 5 to 8% of the congenital. Am I being heard?
Yes, you're
Hello?
being heard loud and clear. We are hearing you. We are hearing you, sir.
Okay, it forms about 5 to 8% of congenital uh, disease, and you could have some associated diseases like congenital rubella, in which patient can present with pulmonary stenosis, they have sensorineural deafness, high abnormalities, and they could also have mental retardation. You could also have patient with Noonan syndrome, in which case said to be due to the mutation in the JAK and the Notch gene. And they can also present with, they usually have a normal karyotype as compared to tuners. They present with pulmonic stenosis. They also have web neck too. They could also have some, they have mental retardation as opposed to tuners, which there's no mental retardation in tuner. And then Williams syndrome too. As a way of embryology, the pulmonary valve is a vital structure in the heart that separates the right ventricle from the pulmonary artery. The pulmonary valve develops from the bulbous cordis, a region of the embryonic heart tube that is around 3 to 4 weeks into the development. The bulbous cordis expands and forms the truncus arteriosus. The truncus arteriosus then divides into the aorta and the pulmonary artery. The pulmonary valve forms from the proximal part of the truncus arteriosus, and by 6 to 8 weeks, the pulmonary valve has fully developed and is composed of the three crescent-shaped cups. You have the anterior cups, you have the right, and apart from the anterior, there's the right and left cups too. And these cups are made of endothelial tissues attached to the pulmonary artery. So that's the pictorial representation. This is the way it should appear, like the three cups. Yeah, but when you have a stenotic, you can see the appearance in a stenotic valve. And this is at the valvular level. Of course, there are different types of the pulmonary stenosis. You can have subvalvular, valvular, and also the infundibular type too. These are the various syndromes. You could have, like I said, the congenital fetal endothelin adaptoin syndrome, which is following the use of anti-epileptic phenytoin. Patient can present with some form of abnormality, pulmonary stenosis in addition to. Then you could also have the allergy syndrome, Leopard syndrome, in which case they present with lentiginous skin abnormalities, ECG abnormalities, ocular abnormalities, pulmonary stenosis. They have growth retardation and deafness too. Like I said, the valvular type is the most common and has the best prognosis, since it can just be balloon open and account for 7 to 10 of all the congenital defects. You have the subvalvular, which is also the infundibular and the supravalvular. And there's a way of pathophysiology due to from the RVT obstruction from the pulmonary stenosis, there's an increased right ventricular systolic pressure and wall stress ensue, and that leads to right ventricular hypertrophy. And when you examine, they have a right ventricular heave and enlarged heart with conspicuous parasternal right ventricular lift too, which can extend to the left mid-clavicular line. They could present with systolic trade, especially when they have a valvular form of the pulmonary stenosis. They have ejection systolic murmur in the left upper sternum, which radiates to the back, that is interscapular area. In severe pulmonary stenosis, there's a loud, long, and harsh systolic murmur that is maximally, sorry, I forgot to say, majorly in most cases, the mild to moderate, they are usually symptomatic, except when they present with severe pulmonary stenosis, that's when they present with palpitations, syncope, and all that. And they present with soft P2. So diagnostic, when you do an ECG, evidence of right axis deformation, incomplete right bond, if mild, it could have RVH. Or chest X-ray, they could have a normal or RV cardiomegaly, and then normal or dilated main pulmonary artery. Intrapulmonary vascularity is said to be normal to decrease. Like I said, the mild to moderate has a good prognosis and intervention is rarely needed. Survival is excellent among patients with mild MS, with 94% of them alive as long as 20 years after diagnosis. A patient with severe pulmonary stenosis usually warrants a therapeutic intervention for relief of stenosis. The treatment of choice is balloon valvuloplasty, usually leading to a 75% decrement in the transvalvular gradient after a successful procedure. The procedure is usually successful if the valve is mobile and pliable, as opposed to those who are calcified and all that. And the prognosis and morbidity subsequent to the procedure are largely based on the right ventricular function at the time of procedure. The hypertrophic subpulmonary stenosis that may accompany the valvular stenosis usually regresses after successful valvuloplasty. A valve replacement may be necessary if the valve is severely calcified or if there is severe concomitant TR. Sorry, there's an algorithm here for a patient maybe with isolated pulmonary system in case of course, if they have isolated PS, that is ineligible to balloon valvotomy or failed valvotomy, severe pulmonary insufficiency, or if you have a hypoplastic pulmonary annulus or dysplastic, if they are present, you want to do surgical valvotomy, but if they are not present, balloon valvotomy will survive. And then if after doing surgical valvotomy, there is subsequent pulmonary regurgitation and or residual PS, you can do surgical valve replacements or transcatheter valve replacement. And then if there is symptomatic PS within complex congenital disease, heart disease, you want to do possible surgical intervention too. And then according to the ACC and AHA, the class 1 balloon valvuloplasty is said to be indicated in symptomatic patients with gradients more than 30 milliliter of mercury, that is peak to peak across the pulmonary valve, during CATs, an asymptomatic patient with this gradient that is greater than 40, and that's class 1. And then for class 2, balloon valvuloplasty, if the gradient across the PV is 30 to 39 by CAT in an asymptomatic adolescent or young. So I want to take the aortic stenosis, which is also the narrowing of the aortic valve in obstruction of blood flow from the left to the ascending aorta during systole. As a way of embryology too, it also begins from the tubular heart structure. That is, the aortic valve develops from the tubular heart structure around the 3 to 4 weeks after fertilization. The endothelial cells from the heart tube differentiate to form the endocardial cushion, which eventually gives rise to the aortic valve leaflet. And between 5 to 7 weeks, the endocardial cushions undergo a process called epithelial mesenchymal transition, where they transform to mesenchymal cells that migrate and proliferate to form the valve leaflet. And by 8 weeks, the aortic valve leaflet are formed and start to thin out, eventually becoming the thin, flexible structure that allows for efficient blood flow. This is the normal structure that you should have with aorta. It should be tri-leaflet, the right and left coronary cups, and the non-coronary. Oh, sorry. But you could have it being bicuspid, appearing in this nature. And then you could also be unicuspid, which could be uncommissural unicuspid, and then you could have a lack of commissural unicuspid, that is acommissural. Sorry, you could also have a quadricuspid too. And then there are also different classification of the AS. You have the valvular AS, subvalvular AS too. Then you could also have supravalvular AS. An example of the valvular AS is the bicuspid. Present in 1 to 2% of the populations and are predominant in men, occur in 9% of first-degree members of those affected. The most common anatomic abnormality seen in bicuspid is the fusion of the right and the left coronary cups. You could have a concurrent coarctation, aortic root dilatation, and a propensity for aortic dissection, as seen in minority of patients. Severe stenosis typically develop by the 5th and 6th decade of life. However, early and late presentation are not uncommon. The male to female ratio is 4:1. It could have some form of AD, inheritance, mutation in NOTCH1, some genes can also be affected. You could have some medial degeneration with ascending aortic aneurysm formation, and always rule out aortopathy. A patient with BAV are tricks of aneurysm formation and also coarctation of aorta. And this can be a component of the shunt complex, in which case you have the aortic stenosis and coarctation of aorta. This is a pictorial representation of bicuspid aortic valve. Here, shown here. Then you could also, the unicuspid valves too can also be found, and they said to open only at one commissure and are common, and they are usually severely stenotic at an early age. The most recent ACC guidelines highlight the evaluation of the aorta and the valve in bicuspid aortic valve with echo. And if this is inadequate, with other imaging modalities such as MRI, CT, in some instances, aorta may require surgical intervention before the valve. Sorry. So under the ACC, the guideline recommends that patient with, patient with aortic diameter greater than 4 cm and bicuspid should have a yearly follow-up of, sorry, I'm not in treatment yet, sorry. So you could have a subvalvular AS2 with a discrete fibromuscular shape below the aortic valve or lesion, and they can be associated with some other congenital disease, that is mitral stenosis, the coarctation of aorta, the shunt, and this may progress in severity. You can also have the supravalvular aortic stenosis, which is the least common of the three types. And then following on the LVOT is a pressure overload. The all forms of AS are characterized by progressive narrowing of the LVOT, and to maintain the cardiac output in the face of increased afterload, the left ventricle must generate a higher systolic pressure, and then this will increase the LV wall stress. And in response to the, hello? Hello?
Chief, we're here with you. We're here with you.
Okay. In response to the pressure overload and increased wall stress, the left ventricle undergoes compensatory and concentric hypertrophy. The increase in LV wall thickness allows the wall stress to normalize according to Laplace law, which says the wall stress equals to pressure multiplied divided by 2 times the radius and thickness. Then following the aortic as part of the pathophysiology, they could also have some form of diastolic dysfunction, which is determined by heavy relaxation properties and the heavy compliance. That is the change in volume with change in the pressure. The increase in afterload following the pressure overload, and then the LVH leads to a reduction in heavy compliance. And then furthermore, there are changes in strain and torsion, characteristic of the LV in AS. The passive early diastolic filling is reduced in AS, and maintenance of adequate LV preload becomes more dependent on an active left atrial contraction. In addition, there's also a supply-demand mismatch. The myocardial oxygen demand is determined by the heart rate, and so with increase in heart rate, there's increase in oxygen demand, and because of the mismatch, so they have a ischemia, and then there's increased contractility and myocardial wall stress too. And over time, LVH is unable to, sorry, just like in addition, just because of the wall stress, the LVH develops, and the LVH is unable to compensate for the increase in wall stress imposed on the left ventricle by the progressive pressure overload. And as the AS become more severe, the wall stress and the myocardial oxygen demand increase in parallel. You could also have the grading of the severity. Like I must be quick to say that they usually have a longer latency period of being asymptomatic.
Cardio, please, can you mute?
I'm hearing you now.
Chineme, please help us to mute the person. Chineme.
Eh?
Chineme, please help us to mute.
But now, go wait TV now, fools.
Okay, good.
Go and watch that soon, eh?
Doctor, okay, thank you.
So for even patients that have severe AS, they said they have a longer period of latency period of asymptomatic, and then following week later they could become symptomatic. What are the features of severity of the AS, at least based on echo? The PG greater than 40 mm of mercury, peak velocity across the valve greater than 4 meters per second, and the valve area less than 1 cm squared. Like I said, AS is usually symptomatic, and by the time they are producing symptoms, you must be sure that they are already having a severe form of AS. Those are the grading of the AS. Yes, the natural history of the AS, like I said, they have a longer latency period. And by the time symptoms ensue, they already are in severe form. And majorly, like especially the bicuspid, like I said, they usually present in the 5th and the 6th decade, though they can present earlier or even later. And then the first, when they present with angina, based on the, of course, the LVOT obstruction, due to the exertional, increase on exertion, they usually present with, angina. And when they present with this, the 50% survivor, they have 2 years. The 50% mortality is like 2 years. And then by the time they present with the synco, so by the time they present with syncope 2, the 50% mortality is about 3 years. And then by the time they present with dyspnea, the 50% survival is about 5 years, 2, 3, 5. Like I said, they have a longer latency period of asymptomatic, and the disease is characterized, I've said this, and because of the variable rates of disease progression, all patients with AS should be advised to report the onset of any symptoms to the physician and should be followed clinically with echo with increasing frequency as the lesion progresses. And as the lesion progresses, once the valve becomes severely narrow, as evidenced by the peak Doppler velocity of 4 across it, the likelihood of developing symptoms or requiring surgical intervention over the following 2 years is said to be very high. This likelihood is increased if they are heavily calcified. Then when symptoms ensue, the survival rate decreases, like I said, and unless an AVR is performed. A patient with angina, okay, I think I've said this. A patient with severe symptomatic AS, sudden death can also occur in the setting of hypotension or arrhythmia due to ischemia or LVH or even impaired AV function. In patients with severe or symptomatic AS, information concerning activity level from family member may be useful in the situation, as may a symptom limited stress echo exercise stress testing is absolutely contrary in the setting of definite symptom. Like I said, in AS, due to pressure overload, they develop an LVH, and then subsequently lead to diastolic dysfunction. There's an increase in filling pressure, increase in left end diastolic pressure. There's increase in pulmonary, and they could present with dyspnea and other features of heart failure. Atrial fibrillation can be fatal in them. Systemic hypertension can mask the AS because the systemic hypertension too can also lead to an LVH. We also have from pressure overload too. So that can, heavy failure or pressure drastically reduces, that is low flow, low gradient AS. It could also occur in association with some syndrome that is presenting with GI bleeding, AS, angiodysplasia of colon, and patient having lower GI bleeding. These are the reasons why they may have angina. That LVH increases O2 demand, there's decreased diastolic perfusion time, there's decrease, and the atherosclerosis too, a syncope due to low cardiac output, dyspnea. So an examination pulse, it tend to present with what we call the pulsus tardus form. And in very severe forms, you could present with associated carotid artery trail, as opposed to patient with OCOM, in which case they have a bifid pulse. So, S1 can be normal, and a loud S1 may be due to aortic ejection click in bicuspid aortic valve. You could have a single S2, which can, when you have a very severe aortic stenosis, when degenerated or sclerosed valve, you could have a soft A2. Bicuspid, you have a louder A2. And severe AS due to LVH. And then when they have a very severe AS, there's a paradoxical split of S2, which can be heard, and this is due to a longer injection time. And S3 can also be heard when there's increase in ventricular filling pressure. This is just about the characteristic of the murmur. Aortic murmur right in the right intercostal space, best side with diaphragm, have a mid systolic murmur with late, as in markers of severity, with late systolic peaking. An high-pitched musical murmur can radiate to the apex, that is the galvadine phenomenon, which is different from a murmur of the MR. And to differentiate between this galvadine phenomenon and the murmur of the MR, the murmur of the MR radiates to the apex, of course, and when you initiate a PVC, of course, the murmur of the AS, of course, will become accentuated, but no change with the murmur of the MR. And then ECG and FVH can be seen, ST depression and others. X-ray, you could see evidence of the dilated, you can have the aortic dilatation here. On echo, you could see technique of the valve calcification can also be seen. Reduced systolic opening of the valve can also be noted. The eccentric closure of the AV valves in congenital can also be noted. And then the valve gradient and the AVA can also be estimated via Doppler. You could also do a dobutamine stress echo, and this is used just to differentiate between those who are a true AS as from a pseudo AS. A cardiac cuts can be done patient with multi-valve disease, in which the role played by each valvular deformity should be defined, and you want to plan for operative treatment. Young asymptomatic patient with non-calcified congenital AS, to define its severity because of the operation or the percutaneous aortic balloon valvulotomy may be indicated if severe AS is present. A patient in whom it is suspected that the obstruction may not be at the level of the aortic valve, that is, those who want to do cardiac cuts, a patient which you are suspecting that the obstruction may not be at the level of the aortic valve, but at the level of sub or supravalvular level. And then you also want to do a cardiac cut to screen for coronary artery disease in patients with severe AS. Consider for surgery with CABG. The medical management, strenuous physical activity and competitive sports should be avoided. You want to avoid dehydration, hypovolemia, because they already have a decreased cardiac output, so you don't want to worsen that. They could have concomitant hypertension, which can be treated, and coronary artery disease with beta blocker ACE. And then nitroglycerin can be helpful in relieving the angina. And the HMG-CoA, that is to slow the progression of the calcification. Surgical management, AVR, preferably prosthetic, is preferred. Patient with symptomatic AS or patient with asymptomatic AS with EF less than 50, Vmax greater than 5 meter, and those with bicuspid aortic valve disease and aneurysmal roots or ascending aorta. So for this form of patient, you want to do AVR. And those who are symptomatic on dobutamine stress test too. And then if they're undergoing any other procedure too, that is, they require cabbage and other. Percutaneous aortic valve valvuloplasty, preferable to operation in many children young with congenital non-calcific AS. Not commonly used as definitive therapy in adults with severe AS because of the high risk of wrist stenosis, but used successfully as a bridge to operation. Hello?
Chief, how are you?
Bridge to operation in patients with severe heavy dysfunction or shock who are healed to tolerate surgery. It is also performed routinely as part of the TAVI procedure. TAVI for treatment, that is transcatheter aortic valve replacement, is best performed using either balloon expandable or self-expanding, or both of which incorporate a pericardial prosthesis. Most frequently performed via a transfemoral route, although trans-LV apical subclavian carotid arsenic has also been used. And this is commonly indicated in when you have an elderly with severe AS who are considered inoperable. I mean, you can't do a surgical, and 1 to 2 year survival rates are set to they are higher with TAVI than the medical therapy. However, the TAVI is said to be associated with an early hazard for stroke, a high index of post-procedural paravalvular AR, a risk of morbidity over the next 2 years. Post-procedural heart block requiring permanent pacemaker therapy is also observed with TAVI. The use of this device for the treatment of patients at intermediate operation risks or for those with structural deterioration of prosthetic aortic or mitral, that is valve in valve, as an alternative to reoperative valve replacement, said to be under study. Yes, here you have different forms of the TAVI, the Evolute, Sapien, and the Lotus. That is the balloon expanding and the self-expanding valve. I showed here. And then this is the coarctation of aorta. Said to be found in 1 in every 1,550 individuals. It accounts for 5 to 10 congenital disease. It's commoner in whites, and males are more affected, ratio 2 to 1. And the disorder is typically diagnosed in childhood, but may go undetected well into adulthood. Most patients develop persistent systemic hypertension, often as children, and are at risk for premature coronary artery disease. Cases usually occur sporadically, but an AD fashion has been also observed. It's frequently associated with bicuspid aortic valve as part of the Sean complex. It is said that coarctation too can also occur in 15% of patients with turners. Potential catastrophic complications can also occur: aortic rupture, dissection, or cerebral burial aneurysm. The mean survival for unrepaired patient is 35 years, with 25-year survival rate beyond 50. The coarctation usually consists of the ductus arteriosus, just distal to the origin of the left subclavian artery. The most coarctation, they are usually just justaductal. The exact anatomy, however, varies, and the coarctation may include the long segment, the transverse arc, or the abdominal aorta. Rarely, the tortuosity of the arc is identified, and the main anatomical substrate is a prominent posterior shape of the aorta, composed predominantly of thickened medial. Embryology, the exact embryological origin remains uncertain, but two main theories exist. The first suggests that the narrowing is caused by the aberrant ductal tissue that constricts the aorta at the time of ductal closure. And the second proposes that the aortic hypoplasia develops as a result of reduced blood flow in utero. This is the normal picture that you have. But when you have, this is like a constriction here. So this is a pre-ductal form of coarctation of the aorta. There's a constriction here, narrowing here of the ascending aorta. I could also be associated with other defects. Like I said, in 85% of cases, 50 to 85 bicuspid aorta, valvular or subvalvular AS2, and VSD PDA, congenital malformation of the mitral valve. A parachute mitral valve could also be associated with a coarctation of the aorta, and as part of the components of the shunt complex, which case they present with aortic stenosis and coarctation of the aorta. Actually, extracardiac defect can also result intracranial aneurysm, especially within the circle of Willis. That is 3 to 5% of cases, hemangiomas, hyposphidias, and ocular defect too. For patients with coarctation of aorta who survive into adulthood, symptoms are usually negligible or non-specific. The matter of fact is also one of the causes of secondary or even angina and heart failure. On thorough cardiovascular examination, ejections, systolic murmur at the left upper sternal border that radiates to the intrascapular area located just anterior or posterior to the coarctation of the aorta. And the murmur may be longer or even into dorsal, depending on the degree of the severity of the obstruction. You could have increased blood flow through the you could have a continuous murmur can be heard when there's increased flow through the collateral, that is in the intercostal artery. A continuous murmur can be heard. Upper extremity hypertension, which is usually systolic, is present in conjunction with diminished and delayed femoral pulsation. Coarctation of aorta should always be considered in differential diagnosis in refractory hypertension, especially in the young. When you do a fundoscopy, you'll find a corkscrew tortuosity of the retinal arterioles can be found. An ECG pulse can be normal or evidence of an AVH or left atrial enlargement. When you do a chest X-ray, in addition to the rib notching that develops by 4 to 2 years of age, due to a large intercostal, you could also have what we call the inverted E sign, one limb due to pre-stenotic limb and the post-stenotic, and the other limb due to dilated left subclavian artery just above the coarctation of aorta. Echo is the most useful in infants and children. In adults, the suprasternal notch view is the most helpful. Color Doppler can be used to localize the site of turbulence. The pressure gradient can be assessed with continuous wave Doppler. If severe narrowing is present, persistence of flow in diastole, that is widening of flow profile from systole into diastole, is seen by continuous wave Doppler in aorta below the coarctation, such as in abdominal aorta. This is a useful method to ascertain the presence of significant coarctation, even if imaging the direct site of the obstruction is impossible. A complete study should measure the left LV size, ascending aorta size, determine the aortic valve anatomy function, identify any other associated abnormality. TE can better define the anatomy if the TT is inadequate. The MRI provides excellent anatomic hemodynamic information, increasingly utilized as first-line investigation before the catheterization, particularly in adults, and this enables the precise anatomy to be delineated and helps in the decision-making regarding the surgery or catheterization as treatment option. Serial MRI scan can be used to follow the result of therapeutic procedure. It is also used in evaluating intracranial because they could have some form of associated barrier aneurysm, so MRI can be used to evaluate them. Cardiac cards provide excellent image data and pressure information and is often more reliable than echo in adults. An aortic angiogram in left anterior oblique or caudal or direct lateral projection usually best define the lesion. The pressure should be obtained in the left ventricle, the ascending aorta, the gradient across the lesion should be measured. A pullback of pressure greater than 50 generally mandates intervention, and the presence of collateral vessel may falsely diminish the gradient. The management. Several factors need to be taken into account in determining the best treatment option for COA, that is, the age of the patient, the anatomy of the coarctation of the aorta, any prior coarctation operation, and the local surgical expertise. And what mode of treatment is choosing? The presence of post-procedural upper extremity hypertension influences the survival. So, in general, the medical therapy for coarctation has very limited utility, but it may be useful in supportive role along the surgical treatment. Hypertension should be medically treated with the goal of controlling BP and preventing the end organ damage. Forms of surgery, percutaneous balloon angioplasty is a form of treatment. It's generally less effective than surgery for primary coarctation of aorta. Excuse me. Neonates and infants treated with angioplasty said to experience high rates of recurrence of coarctation of aorta, about 50 to 60% of them. And then aneurysmal formation in 5 to 20% of them. Therefore, surgical repair is preferred in this patient population. And likewise, balloon angioplasty of the unoperated coarctation in adults is controversial. There are limited data supporting this. Procedural complications you could have from the percutaneous balloon method. You could have aortic rupture, aortic dissection, femoral artery trauma, recurrent coarctation, and aneurysmal formation. The suspected mechanism for late aneurysmal formation is intimal tear at the site of cystic media necrosis within the coarctation site. It should be noted that the clinical impact of aneurysmal formation is unclear, as most defects are small, have low risks of. So percutaneous angioplasty, however, is preferred therapy for recurrent post-surgical coarctation. The procedure is successful in reducing the gradient to less than 20 in approximately 80% of intervention, and with only 1.5% incidence of late aneurysmal formation. Stent implantation is also another form. Stents implantation may mitigate the development of aneurysma or dissection for a few reasons. By opposing the torn intima to the media and through the dispersion of force, stenting may limit the vascular trauma. It can also oppose the vascular recoil of coarcted segment and avoid overdilatation. By allowing the use of smaller balloon and graded inflation in stage procedure, stent may also reduce the rate of aneurysmal formation. I think I can leave it. Surgery remains the therapy of choice in neonates and infants. And 3 types of surgical repair have been used for correction of the resection of the sternal segment with end-to-end anastomosis and use of a subclavian flap and patch aortoplasty. The approach with the best long-term outcome and sustained resolution of obstruction has been the resection of the stenosis segment with end-to-end anastomosis. This approach carries with it the lowest risk of recurrence, that's 3%, and the late aneurysmal formation, which is said to be very rare. Paradoxical hypertension and bowel ischemia may occur in post-operative period. And most surgical complications, paraplegia caused by perioperative spinal cord ischemia, residual coarctation. The survival rate is said to be greater than 90 at 10 years, primarily due to coronary artery disease, congestive heart failure, and aneurysmal rupture. Younger age favorably influences outcome after surgery. Follow-up. Lifelong follow-up is indicated after the diagnosis of coarctation of aorta. The progression of hypertension, either at rest or with exercise, development of coarctation recurrence and aneurysmal, left ventricular dysfunction, associated aortic valve dysfunction when bicuspid is also present. You also want to look out for this. And those are my references. Thank you.
Okay, thank you so much, Dr. Ayodeji. This was really an extensive presentation. At least I saw a lot of answers from MCQs we've attempted. So we really appreciate your efforts. The room now is open to questions and then contributions as regards his presentation. If you have nothing to say, you can actually appreciate his hard work. Thank you so much.
Thank you.
Okay, so the room is open to questions. You can speak up. Dr. Tsubi is saying thank you very much, Chief. You can speak up and ask your questions or make your contributions. Or if you don't have anything, you can just say thanks.